Hey, I'd like to welcome you to another episode of Mission Matters. My name is Adam Torres, and if you'd like to apply to be a guest on the show, just head on over to missionmatters.com and click on Be Our Guest to Apply. All right, so today I have Dr. Jeffrey Gold on the line, and he is CEO of Gold Direct Care. Jeffrey, welcome to the show.
Thanks for having me, Adam. I appreciate it. Happy to be here.
All right, so we have a big topic today. So we'll be talking about putting the care back in healthcare. What does that mean? We'll also talk about the insurance system, just really some of your concepts and what you're doing with Gold Direct Care, and then also Starseed Group, which we'll get into as well. But before we do that, Jeffrey, we will start this episode the way that we start them all with our Mission Matters Minute. So, Jeffrey, we at Mission Matters, we amplify stories for entrepreneurs, executives, and experts. That's our mission. Jeffrey, what mission matters to you?
A real simple mission: fixing the healthcare system in the United States. Very, very simple, right? No, I feel that many people would agree that I think our healthcare system has a lot of good things, but it also has a lot of bad things that make it very difficult for people to access care and quality care. And my mission is I think everybody deserves affordable, high quality, transparent healthcare. And that's what my mission is.
It's a big deal, and one that affects many of us, and excited to get more into some of your concepts and ideas and how you're going about doing this. But how do you get started on this path to really thinking about the whole system, as opposed to, of course, your doctor, but how'd you get into the idea of thinking of the whole system?
Sure. As when I was growing up north of Boston here, I always did well in school and thought about doing some type of service industry that would help people. And my grandmother that I was very close with got ill with dementia pretty early onset when I was in high school. And we all used the same family doctor for our primary care. And he was just kind of non-existent in everything that was going on in terms of helping my family navigate the confusion of the system and the care aspect of it as well. And it just really frustrated me. And, she worked her whole life, paid her taxes, and it was her turn to get help and couldn't. And she passed away a couple of weeks after I graduated high school. And, my mission from that point on was not only to become a doctor, but, really to go into a primary care type specialty and work from the foundation of what our system's about in order to make it better and easier so that no one would have to go through that. And what I realized very quickly is it really wasn't her primary care doctor's fault. It was the way the system is structured that made him absent from the process. And I worked as an employed primary care doctor for a big hospital system for the first 10 or so years of my career. And, it just became more and more glaring to me that, this was not something I could further be a part of, as I felt it was harming more people than it was helping. And that's where I started looking into other ways that we could hopefully, do a grassroots movement to really fix this system for people. And when I heard about the direct primary care model, it was almost like everything in my brain that I tried to formulate over 20 years of training, somebody was already doing in other parts of the country, and I was sold. So here I am.
What a story, number one. And before we go further into maybe the direct primary care model and some of the other components, maybe let's take a step back and talk a little bit more about what's wrong with the system, like what's broken, because I don't want to assume that everybody watching this knows.
Yeah, I think the issue is really it's hard to blame the public because of the way that it's been presented to them. I think the public have been made to believe a couple things. That one, everything we do in healthcare is so expensive that if you don't use a third party system, whether it's government payment or insurance payment to pay for it, you'll go broke, which is not correct. And number two, which is kind of a corollary of that, is that if you have that insurance card in your wallet, you're guaranteed high quality, affordable, accessible care, which is also not true. And I think when you use fear, which, no one wants to get sick, no one certainly wants to go broke, from getting sick. We've created a system where people are disengaged from it and no one wants to interact with it. And kind of like everything we do in the US, in some ways, we're reactive rather than proactive. We wait until people, really what we have is a sick care system. We don't have a healthcare system. We're not paid to keep people healthy and well. We're paid to get them sick and then treat them when they're sick. And with primary care, we want to do the opposite. We want to try to help people live a healthier life and reduce their risk of downstream disease and the expensive parts of the system that are there. So I think, part of that is not having any free market principles. And when people say, well, when I'm having a stroke or I have cancer, I don't care about a free market, 100% accurate. Those are insurable events. But when you look at things that are done on an outpatient setting, whether it's primary care, imaging, specialty care, 80% of your care can be handled in an outpatient setting.
Mm.
And people should know what things cost and the quality of it, just like we do with every other good and service that we access in the US. In health, you ask anybody in the US what's good health insurance, and they say it pays for everything. That's
Yeah.
actually the first type of insurance. Good car insurance is we never use it unless we have to. And what we're trying to do is get insurance back to when it was affordable because it covered things that really were expensive. So we're trying to flip it back on its head in a way.
Yeah, and that's one thing that it's always confused me. And that's, what does something actually cost to me? And maybe there's some other industries but I don't come across them where you don't actually know what the goods are that you're paying for, like what they cost. It's just not the transparency, just the consumer, the knowledge standpoint. I feel like there's a big gap there.
Right.
And
And
has it gotten a little better, or I feel like it's gotten a little better, but a long way to go?
It's a little bit better, but I'll even take it a step further and say it's the only service industry we have in the country where the provider and the consumer of the service at the time of service have no idea what anything costs.
Yeah.
And there's no way you're going to get price control with opaque, non-transparent pricing, and no one knows. And yes, like I said, when you're going in the emergency room with a stroke or a heart attack, no one cares about cost. You just want to be taken care of. That's an insurable event. Everything else, just like with your car, you can go online and you can look, okay, I'm going to get my oil change here, or I'm going to get my tires here, my gas here. I tell people, imagine if the auto insurance industry worked like health insurance. We'd be told where to go for our gas, even if we're on empty and have to drive 10 miles because that gas station's a network, wherein this one's not. The cost would be exorbitant and it would be insane. And yet, what's more precious than our health and our well-being? And we've built a system and allowed a system that doesn't work. It really doesn't. And the doctors and the patients are the ones that are really suffering the most, and without them there is no system.
Yeah. Tell me from the doctor's point of view, like how they suffer, because I think that's an important component of this as well.
That's a great question, and not a lot of people talk about it or ask about it. But physicians right now have the highest suicide rate of any profession in the U.S. Severe mental health issues. We go into this working hard, wanting to help people, and we have no problem working hard when it involves taking care of people, when it involves unnecessary paperwork and billing and coding and fighting with insurance companies and dealing with government regulations. That's a different story. That's not enjoyable and it's not fruitful. It doesn't benefit us. It doesn't benefit the patient in any way. We don't go through medical school and residency expecting not to work hard.
Mhm.
But you want to work hard at what you're passionate about and what you want to do, which is really take care of people.
Mhm.
And I think the third party involvement, whether it's private insurers or public, insurance, is they're the rule makers
Mhm.
and not the patient, not the doctor. And I think, looking at what's going on in today's world with COVID-19,
Mhm.
I think that has really taken a big spotlight and put it on all the dysfunction and the fragmentation that exists
Mhm.
in our system. Is most people don't have a primary care doctor anymore that they can access and have a discussion with
Mhm.
about what's right and wrong and what's best for them. It's what do you see on social media or what do you see in the media?
Yeah.
That's not medicine.
And so one thing that you've mentioned twice, and I just want to make sure everybody caught it, was that, obviously heart attack, you're having a stroke, something big, like that's an insurable event. Like you mentioned, I think you used a car example. So, you're in a big accident. Okay. That's an insurable event, but your everyday visit or a lot of these outpatient procedures that could be done like that, there's a better way to do it. Is that what I'm hearing?
100%. When you actually start looking at what things cost,
Mhm.
for example, some of it is regionally variable,
Of
depending on
course.
where you are, but we can get a screening mammogram for $250, and that
Mm.
includes the radiologist reading the films. So, does it make more sense for a patient to pay $250 a year for that study,
Mhm.
but then be protected? God forbid something's wrong
Mhm.
and they need further evaluation, or get that free mammogram like we have under the Affordable Care Act. But then we have people on $3,000, $6,000 deductible health plans that don't cover anything, which for the average working American, $3,000 and $6,000 is a lot of dough.
Mhm.
So we almost have it completely backwards.
Mhm.
Um, you can't use insurance as a payment model. Uh,
Mhm.
you have to use it as insurance. I always say I'm not anti-insurance by any means.
Mhm.
I'm anti-insurance companies practicing medicine,
Mhm.
and I'm anti-insurance for things that are actually highly affordable.
Mm.
Um, you look at a perfect example I use is look at Lasik eye surgery.
Mhm.
There's never been any third-party payment system for Lasik eye surgery. It's an elective procedure that people pay out of pocket for.
Mhm.
When it first came out, the costs were very expensive. Now you can, the quality of the procedure has gone up, the cost has come down
Yeah.
because you actually have true market forces working where people have
Mhm.
to compete against each other and be better at it. And that's what we failed to see. People say, well, you can't have a free market in healthcare. We've never tried one.
Mhm.
And the biggest, pushback we get is, well, what about the more disenfranchised population?
Mhm.
We need this to be more affordable and accessible so that those people can have access to this type of care. Um, they probably need it more than the average American, but instead, we're focusing on just giving them an insurance card rather than the actual personal relationship with a physician who cares about them and can advocate
Mhm.
for them.
Awesome. Let's go into so I think we've covered, so we have a good basis for the conversation to go forward into some of what can be done. So let's go into the direct primary care model. Maybe start off with kind of defining direct primary care.
Sure. So, kind of like everything else that we've seen develop over the past 20 years or so, Blockbuster doesn't exist anymore. We have
Yeah.
Netflix. It's a membership model. What
Mhm.
we do is we charge, a flat membership fee
Mhm.
to patients where all their primary care is included.
Yeah.
Um, and it's also kind of like a Costco or a BJ's that by being a member here, they get access to labs and meds and imaging
Mhm.
at what they actually cost, not what the hospitals charge.
Yeah.
So, what we encourage them to do is obviously, depending on the patient,
Mhm.
carry at least a high deductible health insurance plan, to cover the major stuff that is above primary care and above
Mhm.
the scope of my ability and training, but get rid of all the barriers to access.
Mhm.
So, we include telehealth, any in-office procedure we do, any in-office visit, everything's included. And it averages about, when you look across the country at other direct primary care practices, it averages about 75, $80 a month per member.
Mhm.
So we're not talking, Beverly Hills concierge rates here that, we get mistaken for. And they also still bill insurance. And I don't begrudge them doing what they're doing.
Yeah.
But here we have no third party involvement. So
Mm.
instead of having to see 3 to 4 patients an hour so I can file insurance claims and get paid,
Yeah.
I see patients for a minimum 45 minutes, whether it's on telehealth, whether it's here. We actually spend time with patients and help guide them through the system so that if it is something that's out of the scope of my ability, they need surgery or they need a more invasive procedure, we help them get to the right
Mm.
place based on cost and quality, so that they know that they're going someplace that they can hopefully afford
Mhm.
and also good quality. Because we took an oath, do no harm. Well, I include do no financial harm.
Mm.
Um, if I'm ordering a medication or a test or a procedure that a patient can't afford, what good is it?
Yeah. And so, on this type of model, and I think it makes total sense, but on this type of model, it's basically number one, transparency. So you're
Mhm.
saying they actually see what it costs. So, some of these very basic things, like as you mentioned, ordering labs or other things that they have access to, like it's a shift. It's a shift to me, and it's a shift in the right direction. And I'm just kind of curious, like, what kind of response have you gotten? Like from and by the way, do we say members? Do we say patients? Like when somebody's
Patients,
part of this plan, like teach me a
yeah,
little there.
my patients. And I think, just to go back for a second, I think the other thing I'd like to say is that, when you look at primary care, and a lot
Mhm,
of us kind of grew up with this, but we've seen it change, unfortunately, for the worse,
mhm,
is it's about a relationship. It should be a longitudinal thing where each other, there's a level of trust.
mhm.
Whereas, if I need my knee replaced, it's great if my surgeon, if he or she has a great bedside manner.
Yeah.
But really, what I'm hoping for is that I get off the table and I can walk again and I never want to see them again. It's more of
Yeah.
a transaction. When you look at primary care, it's really the foundation of our healthcare system.
Mhm,
And we've neglected it and undervalued it for decades. And that's why people either can't find a primary care physician,
mhm,
or using, urgent cares for their primary care, which is not good quality primary care.
mhm,
We really need to rebuild this from the bottom up, and
mhm,
that involves patients and doctors working together to get back all the good stuff that we used to have, incorporating the technology that we have now to make it easier and better and more accessible and affordable,
mhm.
and use insurance for the rest. And it's really, the way I look at it is, in med school, we learn Occam's razor. If you're not familiar with Occam's razor, it's, someone comes in with 20 different symptoms. You're trying to find the one unifying diagnosis that explains everything. You're trying to
Yeah.
take a complex problem and make it simple. That's what we have to do to fix this. We've tried this top down government insurance based approach for decades,
Mhm.
and it's the most health insurance costs the average family more than a mortgage half the time, and it's just broken, and it shouldn't be that way.
And so what's been some of the response you've gotten? Because even just, the fact that you can spend 45 minutes or up to 45 minutes with a patient, like that's I've never even heard of that really. I know that's never been my experience and many of the people that are watching this. I mean, what has the response been?
It's interesting. It's
Mhm.
You realize, I kind of fooled myself into thinking when I left the system to
Yeah.
do this that, I was everybody's favorite doctor until I didn't take their insurance anymore. Um, I expected a line out given how bad the system is,
Yeah.
and I didn't think I was very good at what I was doing because of the system.
Mm.
I thought people would line up, for what I'm charging and what
Mhm.
we're doing and the value of what we're providing. I thought people would line up, but it's taken, a good 6 years to
Mhm.
really get this going, especially in a very big hospital centric area like Boston. I think it's different, if you're in the middle of, Nebraska or Kansas somewhere. There's a lot of factors that go into the success of this.
Mm-hmm.
But it's been a grind, but it's a worthy grind.
Yeah.
You're actually, people say, well, you just have to educate people.
Mm-hmm.
It's actually, you have to uneducate them. You have to explain to them. I actually frame it a lot in kind of the psychological Stockholm syndrome, where people have been captive, including doctors, by this system,
Mm-hmm.
and they don't think there's a way out. So they think it's okay, and they just keep doing more of it. It's like you just said, you've never had a doctor's visit that's lasted a half hour. Well,
Yeah.
why do we keep going back?
Mm-hmm.
We keep going back because it's all we know, and people think, well, would you go to a restaurant, and pay $600 for a meal, like some people do a month for insurance, and have to wait an hour to be seated for 15 minutes with no prices on the menu, and then get a bill 2 months later for $5,000? Like, no one would do that. But yet we do it every day in healthcare. We've all experienced it as patients. We're all patients, and we've all experienced it at some point in time, whether it's with us or a family member or a friend. And it's not okay with me at all.
I want to go maybe a step further into what you mentioned about the role of the primary care physician and how important that is, and especially where there, I feel like there's a lot of opportunity here for this type of model, because, and I'll give you my layman's term of example of how I understand this works, and then please correct me. So something's wrong with you. You go to your primary care physician. In the perfect world, you have a good working relationship that you've been, maybe if you're stood in your hometown, you might have been going to them for years. You have a more serious health problem kind of down the line, or something happens, they refer you off to a specialist for something that may be, in this case, something that should have been an insurable event. But it seems to me like if this model is implemented on the primary care side of things, like it makes for a better just timeline of care, or however you want to say that, journey of care, or as you're aging, all these things. I mean, I just see there's a lot of benefits to it. Am I understanding that right? Or is there anything like to add to that?
No, I think you're spot on. And obviously, I'm biased, by the career and the path that I chose to do. But I think if you looked at hard data, studies that have been done in the US, is that any area where there's a higher concentration of primary care docs than specialists, and this is not anything against specialists, but the outcomes and the patient satisfaction are better. And it's because you need that steward or that pilot or that concierge, whatever you want to navigate or whatever you want to call it, to help navigate you through this labyrinthine system that we've created. Well, not us, but the third parties have created on purpose. The system's not broken for them. There's a lot of people extracting a lot of money from people and not providing any value in terms of patient care. And when you look at data, if you have a better relationship with a primary care doctor, and that primary care doctor is actually able to function to the extent of their training, which now I can by having the shackles off me, your downstream costs are significantly lower. We're not referring as many people out. We're handling more problems in-house. I don't think the general public even understands, and it's not their fault. They just don't understand what real primary care can do. We do, mole removals, skin biopsies, joint injections, laceration repairs, tons of things that when you're seeing people in an 8-minute increment, you don't have time to do. So it's go see this person, go see this person. And you've already lost the patient at that point. And, what we're trying to do is really keep as many things here, which is affordable, accessible, transparent, and keep them out of the expensive part of the system if it's medically appropriate.
It's great. So as we start, as you mentioned, introducing this system, you've been working on it, 6 years to really get it going. Like, while you're uneducating, right, the general public on how healthcare can be and educating them on another model, and like, how does this work into scaling? Like, so overall, obviously, huge system starts, one person at a time, but like, how does this work into scaling this model?
It's a great question.
Yeah.
And to be truthful, it already is scaling. I mean, since I opened in Mass 6 years ago, I mean, I was the first one to do it. There's about 15 of us now in the state.
Wow.
So it
That's
is,
amazing, by the way. I mean, that's gotta feel, I mean, obviously 15, it's from you. That's amazing.
yeah. I mean, it is. And this is
Yeah.
probably one of the most overregulated states when it comes to healthcare to do anything different. I'd probably throw your state of California right in
Yeah.
there too. But I think if you look across the country, there's probably a little over 2,000 of us now. Now, it's a very small percentage of overall primary care doctors in the country,
Mhm.
but it's it's the only way that we rebuild a model
Mhm.
to attract more medical students and more people to go into primary care again. I mean, this is a dying field,
Mhm.
and I really feel that this model is the only sustainable way of getting medical students back into primary care so we can fix a lot of the shortage,
Mhm.
especially in rural areas where, some people can't find a doctor for 100 miles.
Wow.
We need to fix that. And when you look at primary care, really, like you said, it belongs in the community. It doesn't belong at a big hospital. We need those big hospitals for all the really, really sick people and the really rare stuff, but primary care really needs to get back into the community,
Mhm.
and kind of, and that's what we're trying to do is fix it one doc and one patient at a time. But I think the scalability to make it easier for docs and patients
Mhm.
to enter this type of business model is, whether you like it or not, when you look at the US, most
Mhm.
people in the country get their benefits through their employer.
Mhm.
And I think when you look at self-insured employers, which, the self-insured industry
Mhm.
is growing more and more, even getting down to smaller employers and companies because they can't continue to afford the cost of these fully insured plans that, whether you have a good year or a bad year, go up 20% every year in premium.
Yeah.
Um, so, when you find the right benefits advisors and the right people whose incentives are aligned and the right business owners, when you look at a company, their second or third line item on their cost or their expense
Mhm.
column is health insurance,
Mhm.
right behind salary and you know supplies or whatever. But
Mhm.
y- they've got to have some type of assistance knocking the costs down, but
Mhm.
also improving the care that their employees are getting.
Mhm.
And I think this model does that. And once we get a few, major, medium size, bigger size companies that create the demand, then we can say to other docs, I mean,
Mhm.
I had an angel investor that helped me get going. Most docs are not going to do that. They're not going to put themselves in more debt than they're
Mhm.
already in
Yeah.
to do this. I couldn't do it anymore. So I took out a
Mhm.
mortgage for my professional career,
Mhm.
and I'm glad I did it. And it's the first time I've been in like major debt, but we'll figure it out. And I'm at least doing what I enjoy doing. But a lot of primary care docs are risk averse. They're not going to
Yeah.
do this without some guarantee. And the only way you can provide a guarantee is if you give them lives to take care of.
Mhm.
So I think trying to move into the employer sponsored self insurance model is really the way to go, because this can just be baked in to the plan.
Mhm. How does Starseed Group fit into this in the scaling portion of things in your model?
Yeah, so the Starseed Group is really in its infancy.
Mhm.
We incorporated about a year ago, and it's kind of just a brainchild at this point. But if you look up the definition of Starseed, it's going to sound a little wacky, but it's kind of a term for someone who comes from almost like a different universe to come to
Mhm.
Earth to do something good. And once they have accomplished their mission, they're done. And that's kind of where we came up with the name. And it's me and two buddies of mine. One is a benefits advisor that works in the self-insured industry, and the other is an attorney who they've both been very successful. He works with self-insured companies, representing them, in claim subrogation and self-insured plan documents and all that kind of stuff. And really, we're going to try to work, because I'm not a benefits guy. I just
Yeah.
want to take care of people. But I want to help more of my colleagues get out of the system so they can practice medicine the way they want and the way that they should.
Mm-hmm.
And I want to help patients get better access to affordable care.
Mm-hmm.
So we see it as a way to really build, a very simple platform or plan option where a CFO of a company can offer their employees Plan A, which does not have direct primary care incorporated. So if they like their doctor and they have a great relationship with them, they still have coverage, but they may just have to pay for copays and
Mm-hmm.
deductibles and all that stuff. And then there'll be Plan B, which is the direct primary care plan option, where the employer will cover their monthly fee to us, or my colleagues in other areas of the country. And they'll have the plan in place that, God forbid they need more expensive service or
Mm-hmm.
hospital or specialty care, they're protected. But our hope is that, which is already being done in other areas of the country,
Mm-hmm.
show that a company is looking at about a 20 to 30% savings on their health insurance spend.
Wow, that's significant considering like how high up that line item is, right?
Yep. And what people, they look at a lot of this is, there's resistance with benefits advisors too, because,
Yeah.
or in this case, brokers, because they're looking at getting paid their commission,
Mm-hmm.
selling them a fully insured plan, and then I'll see you next year and I don't have to do any work and the rates will go up.
Yeah.
When you're working in the self-insured benefits model, you really are an ongoing consultant where you've got to look at the claims, you have to look at
Mm.
the day-to-day spend, the pharmacy spend, and really help manage the plan.
Mm.
When you look at companies, their fiduciary responsibility,
Mm-hmm.
with their 401k, they take very seriously. They can't just go buy different funds and put them
Yeah.
in a plan that aren't good. Well, yet if you're self-insured, you're the fiduciary responsible party is the company,
Mm.
and they're not managing this. They need help, but they've got to start looking at other opportunities and other ways to mitigate their risk, give their employees something that's beneficial. I mean, all we're doing right now is just shuffling deck chairs around the Titanic.
Mm-hmm.
It's unsustainable this way. Inflation's going through the roof, but yet
Mm-hmm.
raises aren't there.
Mm-hmm.
Benefits are not improving. Well, this is a way we do that. If you have happy employers, happy employees or patients, happy doctors, you're already three steps in the winning direction.
Yeah.
So it's just really finding the right employers that care about their employees, care
Mm-hmm.
about their bottom line, and work with us to really accomplish what the ultimate goal is, which is better care of people
Mm-hmm.
at an affordable rate. And that's really what we're all about with what we're trying to do.
Man, what a great story. Like it's exciting to bring this to my audience because you said about 2,000 strong plus in the country. So as you see this number grow, as you see this concept continue, as you see the uneducation of us understanding like how I thought it had to be this way, because I'll be the first to say I thought a lot of the things that you mentioned it kind of had to be this way. I didn't really understand that there was an alternative model that could work better for me and could also work better for a lot of other people, which ultimately, I mean, the goal here, on both, I won't say sides, but from all parties, I would argue, like, feel like the goal is definitely better patient outcomes. Like that's a goal. And I feel like this is a way that can help, rebuild the system so that that could be possible. And then we're also on the other side of things, looking at the doctors and their well-being as well.
Right. Because I mean, if your doctor is
Mhm.
not well, particularly
Yeah.
from a mental health standpoint, you're not going to get good care. And, we need to take care of ourselves too. I mean, obviously, our job is to take care of people the best we can, but we can't do it if we're not well. And I think, I know too many of my colleagues that have suffered from depression, substance abuse,
Mhm.
just by burnout, from
Mhm.
not being able to do the job that they want to do, which is really just simply take care of people.
Mhm.
Um, you know, we we think insurance is important, and obviously we work with people to help make sure our patients get the right coverage for
Mhm.
where they're at. If you lost your job and lost your insurance and you came to me and said, Jeff, I just got diagnosed with lymphoma, what do I do?
Yeah.
I'm not going to tell you to go on a high deductible plan because you're going to meet your deductible within a month. You're
Mhm.
better off that year paying a higher premium for a lower out of pocket
Mhm.
than if you were coming to me healthy and overall in good shape with,
Mhm.
maybe a little bit of high blood pressure or whatever. Why are we giving all this money to the insurance companies
Mhm.
when we could keep more in our pocket, pay the doctor directly at
Yeah.
a reasonable rate, and get all this affordable stuff? I mean, I've
Mhm.
saved people literally going to our local hospital system for 6 lab tests that were billed. They were billed $600
Yeah.
through their insurance because of their deductible. Same 6 lab tests that we get cash, we draw the labs right on site, were $65 total.
Wow.
So that literally is almost like a year of care to me.
Yeah.
So I look at it that if we get this all the time. I'm young, I'm healthy, I don't go to the doctor much until you actually need it. And that's not
Yeah.
necessarily a good thing, is that you're waiting,
Mhm.
until you need it. We can, if we prevent one emergency room visit that's not necessary, you've made your money back.
Mm.
It's that.
Totally.
I mean, I have anecdotes of money that I've saved people in the thousands in one day, just
Yeah.
by helping them shop for medication or an imaging study. Um, but it's not the type of consumer good that you can just go online and figure this stuff out on your own.
Yeah.
You need an advocate, and that's what we're really supposed to be. In primary care, is your advocate.
Mhm. So, Jeffrey, first off, this has been great having you on the show. I learned a lot. I hope my audience did as well, about different ways to look at the healthcare system and also the primary care model and what that looks like. So, I just have to ask, so what's next? What's next for you? What's next for Gold Direct Care, Star C Group? I mean, what's next?
I think it's just a continued battle. It's very much a David versus Goliath type movement. And I think it's a really important social movement. I mean, I think
Mhm.
most of the inequities that we see in our society, healthcare is a big part of that. And
Mhm.
there's too many inequities going on. And I think that, I want to continue to try to get this to as many people in the US as possible. I think everybody deserves this type of relationship with a primary care doctor, whether it's me or one of my colleagues or
Mhm.
anybody. But I think patients and employers really need to start asking the hard questions and start researching and finding us. The drawback of our model is we work on a very low overhead.
Mhm.
Um, we don't have money to get a big PR firm or marketing firm to go sell this for us. So it's very grassroots. And I think, you know, people just need to start looking out for us. I mean, there's websites that people can find a direct primary care doctor in their area. There's 49 states now that have at least one direct primary care doc. South Dakota is the only one that doesn't yet.
Mhm.
So we're really trying to help patients, and that's really what this is about. Is how do we build a system that works for the patients?
Mhm.
And right now, it doesn't. Um, and I think we've all experienced that. And I think you have to ask yourself, how do you want to be treated, and how do you want your loved ones and family to be treated?
Mhm.
Because that's what everybody deserves, regardless of income status, race, color, doesn't matter.
Yeah.
We're really trying to do what we think is the best thing, because I think we have plenty of evidence that the top down approach hasn't worked in decades.
Mhm.
Um, so, we just encourage people to continue to educate and read and, and ask themselves, what do they want, and
Mhm.
look out for us,
Yeah.
because we have to fix this together.
Mm. So if somebody's watching this and they want to learn more about Gold Direct Care or to connect with you and your team and follow the journey, I mean, what's the best way for them to do that?
The best way is, we have a website, www.golddirectcare.com.
Mhm.
They can email me directly. I love getting emails. My email is open all day. It's Dr. Gold, DRGOLD, at golddirectcare.com. If they're in other areas of the country, where they're looking for, where they didn't even know this existed, but
Yeah.
it's something that they're interested in. There's a couple websites. dpcalliance.org has a finder on there, and dpcfrontier.com has a mapper on there where you can type in, your zip code, and find a doc, that's within a reasonable distance to you. But we're happy to talk to an employer. We're happy to talk to individuals. We're just trying to fight the fight.
Fantastic. Well, and to the audience, we'll put all of those links and things in the show notes, so you can just click on them and head right on over to those websites. And if this is your first time with us at Mission Matters, we're all about bringing on entrepreneurs, executives, and experts, and having them share why they do what they do. Like, how are they going out there and trying to make a difference in the world and in the marketplace? If that is the type of content that you're into, we invite you to hit that subscribe button, because we have many more mission-based individuals coming up on the line, and we don't want you to miss a thing. And Jeffrey, really, it has been a pleasure having you on the show and learning more about the model and just what you're doing out there. So thank you for coming on.
Well, thank you for having me, and let me preach my gospel. I appreciate it.